got to a point where like a lot more contact.
Hey everyone, I'm Maureen Cunningham. I'm one of the investigators at the Center for Global Health, and it's my pleasure to introduce Beth Fischer, who's a Denver-based senior technical advisor for IntraHealth International, and she has extensive global health experience in maternal and child health. But her presentation today is going to focus on a project that she did with IntraHealth International, focusing on an mHealth intervention that was funded by the Bill and Melinda Gates Foundation and helped community health workers deliver maternal and child health care in India.
Thank you. Well, welcome everybody. I'm so glad that you made it in out of this chilly day. And I'm going to ask you to transport yourself with me from all this snow and cold to the warm climate of India. And we're going to talk about an application in India. So India this time of year is actually quite pleasant. The weather's nice. It's not too hot, not too cold. There's no rain. So it wouldn't be a bad place to be on a day like this. I want to just get a sense of the audience. So how many of you have ever been to India? Okay, so we've got a couple people. That's good. And how many of you have ever worked with any kind of mHealth application? And a couple more. Excellent. So I'm hoping that we can all learn together then through this presentation, because one of the reasons I like to do this is to hear what others are doing and what their experience has been. So let me just share with you the outline. What I'd like to do is just highlight a little bit for those of you who have not worked so much in mHealth on how mHealth is being used in low resource settings. And then we'll talk a little bit more about the Indian context in this particular application that we work on. So when we use the term mHealth, what we're really talking about is the use of mobile technology to support health outcomes. So mobile technology are, our smartphones or our regular mobile phones, tablets, anything that's very portable. And we make that distinction from e-health, which would be more computer-based or other kind of electronic that's not so movable. So that's just this is a whole new field, so the terminology is actually even evolving as we move on. And I know this information is out of date, but I think it's gotten so out of date that it's hard for anyone to keep track of it. But as of a year or two ago, there are more than 1,000 mHealth interventions worldwide, many in developing countries. But I know that number is much higher now because we're constantly reading about different applications that are being developed and used to the point where it's really hard for someone to actually kind of keep cataloging and maintaining a database about this. One of the things that we know is that many of these interventions are really at pilot scale. We're really trying to demonstrate and do proof of concept and see if these applications work. And one of the challenges that we're all experiencing is how do you both scale and sustain some of these applications. We're going to spend some time talking about that, and those of you who have worked with mHealth innovations, I'd love to hear your thoughts on that as well. So we see mHealth applications in low resource settings being used in just a wide variety of ways. They're certainly being used for information systems, for collecting data and sharing data, kind of replacing paper-based reporting tools. They're being used, and we're actually using another innovation in some of our work in Senegal for supply chain management. So helping health facilities keep track of their drugs or when they're out and reporting stockouts. Workforce development is another area where we're seeing some of the mHealth applications, and the one that I'll talk about has very much that component where how do you strengthen the workforce, build their skills, give them knowledge and learning. We see mHealth being used for financial transactions increasingly. And if any of you are familiar with Kenya and the M-Pesa program, that has just exploded in East Africa and other countries where it's mobile money. And I was in Uganda just a couple weeks ago, and all of my staff were using mobile money. That's how transactions are now done. So it's really almost substituted for the banking system in a number of these countries because of the ubiquity of mobile phones. And then we're also seeing it for social and behavior change communication and service delivery. So lots of uses. That's what's exciting about this and why I think there is so much innovation going on. Because there are so many different ways that we could use the mobile technology for public health. So let's talk about India and where we were working. So India, as you know, is the second largest country by population in the world, about 1.26 billion people. So everything is at mega scale in India. Even if you're working at a small scale, it's still relatively large scale. In terms of maternal and infant mortality, India contributes around 20%, 19% of all maternal deaths globally, and 29% of newborn deaths globally. So just that one country is a huge contributor to our overall maternal and newborn health indicators at a global level. And again, I think that's why it attracts attention. So Uttar Pradesh is the state in which we're going to transport ourselves today. If Uttar Pradesh was its own country, it would be the fourth largest country in the world, 200 million people, 75 districts. It's in the middle part of the country. It's one of the poorest states in the country and also has some of the worst health indicators. So one of the context setting that I wanted to provide in India is just to understand a little bit about what is causing all these maternal and newborn deaths. And so you can see for maternal deaths, the major causes are hemorrhage, sepsis, obstructed labor. But some things that the point here is that these are things that really could be addressed if people had better access to care and were able to have better both antenatal care but access to skilled birth attendants. And so there's been a real push to try to do that.
Do you want to be interrupted with questions? Or would you
Yes,
rather not?
I meant to mention that, so
Okay,
I'm very
sorry.
glad you did. Please go ahead.
What do you think is in that other disorders? Are we talking about preeclampsia stuff, or what's in that big 34%?
The preeclampsia is probably in this hypertensive
disorder, yeah.
disorders.
So what do you think's in that big?
I would have to look what some of these, I can't remember. It is kind of a hodgepodge of things.
Number, yeah.
Let's look at newborn health. I can get you that information. It's just not the things I remember off the top of my head. Newborn health, some of the same issues. These are conditions that are treatable if you had access to care. So prematurity and low birth weight, you can control that by having good, strong antenatal care and counseling around nutrition and what have you, and management of diseases. Birth asphyxia and birth trauma, again, can be addressed if you had access to skilled birth attendants. And then neonatal infections, obviously they occur a lot more if you're not in a medical facility. So all of these things are things that are could be improved on to really bring down those maternal and newborn health numbers. And as a result, the government of India has really tried to invest substantially in that through what they call their National Health Mission. It was originally called the National Rural Health Mission. It's now been expanded to urban areas, and it's called the National Health Mission. And the government has been intentional about making strong investments in strengthening the healthcare system. India's system is such that the government sets policy at the national level and provides a substantial amount of funding, but actually most healthcare is structured at the state level. India has a very strong state system. So these monies come in as kind of earmarked funds to the states to then try to improve their systems. But the National Health Mission has as one of its core features really trying to increase access and quality to health facilities and institutional births. And the other thing it has is creation of a brand new cadre called the Accredited Social Health Activist, or Asha for short. There are about 800,000 Ashas in India. So one of the reasons Ashas were created is because India, like many low-resource countries, has an enormous shortage of skilled health professionals. And so these women are community-based women, generally low literacy. They may have, they're supposed to have up to an 8th grade education, but often they don't have that. They receive 23 days of training in kind of basic maternal and newborn health and a little bit of family planning. And they're really supposed to be the activist, the advocate, the connector for people living at the village level where they themselves live, to get those people to go to health facilities for delivery, to get those women to go to antenatal care services, to get those women to take their babies for immunization. So they're really that community health worker. And they really are a key link to the community. So these Ashas work along with two other health workers that are, one is sort of at the village level and one's at a higher level. The Anganwadi worker, I'm not going to spend too much time talking about that, but that's, again, a community health worker that's been around a bit longer and is focused on nutrition and early childhood education. And then the auxiliary nurse midwife, who is the first line skilled health professional. This person has about 18 months of training and is supposed to be able to conduct deliveries and do basic primary care. So that's the first point of contact. And what we see within this team, and then certainly within the Ashas, is that they really don't have a whole lot of resources and support. Very hard to do supervision on 800,000 people when you don't even have that many A&Ms or others to be able to do supervision. Very limited training, so they get these 23 days in modules, but then there's really not much opportunity for follow-up or for any kind of support that's required.
Who does that training?
The different state governments will do the training, and
So
sometimes they do it through locally based NGOs or what they've created these Asha training resource centers.
But they're health professionals, and it's geared towards the illiterate people.
The trainers aren't have health background, but I don't know that they're all health professionals.
But there's
They're more like public health
visual
people.
training as well as reading.
Yes, they all have a module, but you have to be somewhat literate to really appreciate the training, and that's why sometimes these Ashas get the training, and then when they're out in the field, may not be able to perform as one would hope. So M-Saki means mobile friend. Saki is friend in Hindi, which is a term we coined to describe what we developed, which is a mobile phone application to help these Ashas, to be kind of a job support for them and to help them be able to perform their work more effectively when they're out in the village. So it's an interactive smartphone-based application, and we have it designed for Ashas. I'll explain a little bit what we have for A&Ms. But some of the key features of it are that it uses both audio and graphic capabilities that are found on phones, and also has some short embedded videos to address just this issue about literacy and ability to be able to absorb information orally and visually if you can't do lots of reading. And it's really designed to accomplish a number of those different things on that wheel that we saw earlier. It's a self-learning and counseling tool. So Ashas use this to increase their own understanding and their own knowledge. So it's sort of a built-in refresher course, if you will, on the different topics that Ashas are supposed to know about. But then they also use it when they're interacting with women in the villages, when they're doing I should have mentioned, Ashas are expected to do home visits to women in the villages, to pregnant women and recently delivered women. So they use the tool also as a counseling aid. It's a decision support tool as well, particularly in the newborn module of the tool. We have built in the decision support algorithms associated with the integrated management of childhood and newborn illnesses. So it's easier for Ashas to then diagnose what might be wrong with a newborn, or whether that newborn needs to have referral or should just be providing counseling around home-based care. So it has a decision support tool, and then it provides for real-time monitoring and management. By the way, it keeps track of whether somebody has been visited and when they've been visited and were they visited within the time frame that was expected. So it has a number of different features that we'll talk a little bit more about. when we designed this, we were really thinking along the reproductive, maternal, newborn child health and adolescent health continuum, which in India is called the RMNH Plus A, which you can say really fast if you see it a lot. And here you can see some of the things that are in the application now, and some of which are being still developed and tested. So there's a component around registration. It's very important to then be able to track these pregnant women to make sure that those pregnancies are registered, and when they have their child, they're registered so they can have immunizations and all. Family planning counseling, ANC visit schedule, the home-based newborn care tool, immunization. So a variety of things, but it was really designed to address that whole continuum. And what we have then is a smartphone application that is used by Ashas in their work in the villages when they're going out doing home visits. The A&Ms have a different application. We've developed something on a tablet base because the A&Ms are the de facto supervisors of the Ashas. So therefore they have some other tools in their tablet application where they can track all the Ashas that they're supervising to see if they're doing their visits and if there's any alert or they've uncovered something in one household that requires the A&M to then follow up with someone. It facilitates that kind of communication. All that information, both from the smartphones and the tablet app, then all feed into the MCRP server, which is where you have the data aggregated and can be used more by the program people and the policy people at the block and district levels to understand what's happening and how their coverage is working, or where access may be poor, or where they have some concerns about quality. So that all gets fed in. It also provides some, we use a lot of Google Analytics and others that just very simple tools that can then help you understand how often these Ashas are really using the tools. Any questions on any of that? Go ahead.
Question. Do you store protected health information on the app? Do you, because I saw that you were saying that you kind of monitor.
Yeah, what's stored on the app is their name and date, the date of their expected date of delivery, and then their village information. This is a whole. It's a very different environment working in than you are here with like HIPAA requirements and things like that. So the information is stored on the phone or transferred into the server, but then there's protections on who has access to that information. So it's the Asha who has access to the information of the A&M.
Is it a cloud-based server, and is that a concern?
At this scale, we're not cloud-based yet, and cloud-based is a concern in India. So that's one of the things that we've been struggling with as we think about scaling and sustaining. What kind of server capacity would you need, and where do you want that to reside?
Is there a link to the outcome of delivery? So does the nurse and midwife record in the same system? There was a delivery complication, and then you could look back and see, oh, they did or didn't use the app, or what was the...
Yeah, no, it's not that sophisticated yet. That would be interesting. But a lot of times the Ashas are accompanying someone to the hospital for birth, and then they will do follow-up afterwards, so they get notified if there's something when that person has returned home. But as far as tracking the outcome of the birth of the newborn, there isn't anything in that. Yeah.
The information that's transferred to and from, is that transfer encrypted, or is it just kind of like free flow of information?
I don't think I know the answer. That's okay. Yeah. Unfortunately, there's some of these technical specifications of the app that I do not know, and that's an interesting question though. So I want to find that one out. Whether it's encrypted data or not, I'm not sure. Okay.
Are the phones restricted so they can't be used for private use?
No. In fact, the phones can be used for private use as well. This is an application that's loaded on the phone, and then these Ashas get to use the phone. So they can use it for regular phone calling and messaging, and in fact, they do use it that way as well to communicate with the A&M or with the health facility or other things that they need. So it actually becomes a benefit to them as part of their.
Are there issues on who pays for airtime?
At this scale, we're paying for some of the airtime for the MCRP app. If they want to need more airtime than that, then they have to pay for that. Let me, I want to show you just a short video of the application, and I think that can explain it even better than I can verbally. So let me try.
With 56,000 maternal and 900,000 newborn deaths, India accounts for 19% of all maternal and 29% of all newborn deaths globally. Accredited social health activists, Ashas, India's cadre of community health workers, could prevent a large number of these deaths by supporting women and their families to access skilled care at birth, adopt healthy measures, recognize maternal and neonatal danger signs, and promptly seek care. However, existing paper-based job aids such as text-heavy reference materials, difficult to carry counseling flipbooks, complex newborn checklists and reporting formats hinder Ashas to optimally contribute to improved maternal and newborn health outcomes. In this context, the Manthan project, funded by the Bill and Melinda Gates Foundation and led by Infra Health International, developed and tested mSakhi. mSakhi is an interactive, vernacular, audio-video guided mobile application that provides support to Ashas in conducting day-to-day activities across the mother and child continuum of care. mSakhi uniquely combines the functions of existing multiple paper-based tools and provides Ashas with critical maternal and newborn health information. mSakhi not only helps Ashas in managing and scheduling their home visits, but also assists them in counseling and assessment. Auxiliary nurse midwives use mSakhi for real-time monitoring of Asha activities. mSakhi's content is based on the National Rural Health Mission training manuals and home-based newborn care guidelines. Let's see how mSakhi works. An Asha registers a pregnant woman into mSakhi. In case she is not comfortable writing, she can register a beneficiary by recording her name and tagging a photo. During the pregnancy, Asha counsels beneficiaries using multimedia messages. mSakhi help Ashas prioritize messages as per the stage of pregnancy. Once the woman delivers, Asha captures the birth in mSakhi, and it, in turn, generates a postnatal home visit schedule for Ashas. The schedule is again color-coded for easy readability. A postnatal visit using mSakhi helps Asha counsel mother and families on home-based care, assess the newborn and mother for danger signs, classify sickness, and provide treatment or referral as indicated. The ANM as well is informed of all key indicators for her Ashas on her mobile phone in a real-time basis using a screen widget and mSakhi ANM app. mSakhi currently generates monthly HBNC home visit voucher cum report for Ashas to claim their incentives. The mSakhi web interface allows real-time monitoring by health officials. MSAKI's impact was evaluated through 2 operation research studies which showed encouraging results. MSAKI's average monthly use per Asha as a self-learning and counseling tool increased from 54 minutes to 121 minutes during the study period. Moreover, the counseling skills and ability of Ashas to deliver complete and relevant messages to beneficiaries was significantly better among the Ashas using MSAKI. Knowledge of Ashas using MSAKI on mother and child health issues was found to be significantly more than their peers using paper-based tools. Ashas using MSAKI during the postnatal home visits were much more likely to identify sick newborns than Ashas using paper tools. The beneficiaries also show a greater liking for MSAKI.
दिक्कतें पहले बहुत थी, झोला ला दो, सब लोग को इकट्ठा करो। अब हम घर घर चले गए तो एक एक को लेकर हम पूरा दिखा देते हैं, मोबाइल लेकर चले जाते हैं, क्या लाना है हमें।
With 56,000 maternal.
Wanted to do. Here we go. Okay, so I hope that gave you a little bit more of the feel and the context of the environments that these people are working in. It's certainly not very sophisticated settings, but you can see how it's a tool that really has helped with their work. What I'd like to do is talk a little bit more about the evaluation methodology that we used and recognize that this was kind of a proof of concept model when we initially developed it. So we weren't operating at large scale, but we did conduct some operations research in 2 different categories. The first category was really to test this as a learning tool. We were interested to know whether Ashas who are using MSAKI compared to a control group for those who were just using the existing paper-based tools and paper records, did they have improved evidence of knowledge around key maternal and newborn and child health? And then the second OR study was really looking a little bit more at skill-based, particularly around newborn care, to see if Ashas using MSAKI were better able to identify and refer sick newborns. So I'll just talk about a little bit about both of those studies in terms of what they showed. So our scale here is not enormous, particularly if you think of 125,000 Ashas. But we were really working with about 146 Ashas who were broken into control groups and intervention groups. And then we did observations of Ashas during home visits, and then we also did a beneficiary survey of about 450 beneficiaries. So that's what this data is based on.
Was it people randomized to?
No, this is not a randomized control. It was more of an operations research, but not with a randomized control component to it.
So I guess was the decision of using Asha sort of MSAKI left to the Asha, where the people who liked it used it, the people who didn't not?
No, it was more purposeful. I can never say that word, but you know the word I mean. Sampling, yes. Where we were working within a block. A block is a sub-district of a district. So we were working in a block, and then we had some Ashas who were associated with using MSAKI, and some were selected not to. So it wasn't their choice. We did assign, but it wasn't a rigorous, randomized. I wouldn't want to claim that because it wouldn't be accurate. What we did find, though, is that the usage, one of the things that we wanted to look at was, are people even using this? So you can train them. And our training was very minimal, you have to understand. I think it was 2 or 3 days. So this isn't that the Ashas who are using MSAKI got a lot more training. the control group also got training. There was this basic training on what the job aids were that they should have already known, but there was a refresher. And then the people who were selected to use MCRP were trained on how to use a mobile phone, because a lot of times these women had not used mobile phones before. There may have been one in the household, and increasingly there are now. This was even a couple years ago when we first started this, so it wasn't as common. And if there's a mobile phone in the household, who do you think owns that mobile phone? Husband. It's certainly not the women. Women are have such low status in India. So a lot of times they didn't have the ability to know how to turn on the phone or manipulate it. So there was some amount of training that was needed, but it was also pretty minimal. It was done in 1 or 2 days. So we were very interested to know, are they going to use this thing? And what we found is that, in fact, usage did increase over time. So the average usage per month, you can see, by the third quarter was about 120 minutes a month. So a good 2 hours a month using it. Their home visits typically are pretty short home visits. They're about anywhere from 5 to 15 minutes. And each Asha, there's actually some more background I should have provided you. An Asha is responsible for a village of about 1,000. And so within that village, there will be a certain number of pregnant women and recently delivered women. And that's who the Asha is maintaining. So it's not that they have huge numbers that they're working with, but a fair number. What we also were able to look at is what were the modules that the Ashas were using? What were they referring to? And this was interesting as well. So we saw a lot of referral for ANC and PNC, which are some of the key functions that the Ashas perform. So this is good. This is the knowledge we want them to have and the skills we want them to be imparting. Complementary feeding, immunization. So they're really looking at all the modules, but those modules that they interacted with the most were PNC and ANC. And we also found when they were acting, one of the things I find so interesting about these mHealth applications is there's a lot of data just to be collected on the back end. So this doesn't require any surveys or anything. This is just the user data that you get from the mobile application itself. And we could find out when were they using it. So what do you think that might have told us, those hours, if you look at those hours down below? Any ideas on how you might interpret that data? Go ahead.
Maybe during the day, that's when they're out, doing their visits, and then during the evening, they're at home, kind of refreshing. Or
that's exactly right. That's exactly right. So we were encouraged by that because it means that they were using it as a job aid as we wanted, but they were also motivated and really using it as a self-learning tool.
This is distinguished specifically the MCRP as opposed to using the phone for other things?
Yes. Yeah, no, this is only using they would have had to access one of these modules in MCRP to register use. Good question. So in the first OR, what we did find is that the knowledge levels of Ashas who were using MCRP was better than those who had been relying on the paper-based tools and the job aids. And these are composite indices on different knowledge scores. And I see now the data is not there, but the first one is on some of the maternal health outcomes and newborn outcomes. I apologize. It looks like my key is missing on that. But we found that Ashas were more likely to deliver complete messages to beneficiaries, and delivering a complete message was a composite index as well. But they were more likely to deliver messages around the importance of completing 4 ANC visits, anemia, on all these key factors. All were found to be statistically significant. Even though we had small samples, we were able to do the statistical analysis on that. So better knowledge and counseling around nutrition, danger signs for the newborn, for the mother, for child immunization. And then for the second OR, we were really testing more skills than just knowledge. Here again, it was very encouraging because we found that the Ashas who were using MCRP had a higher knowledge of critical newborn care conditions. They were able to name at least 6. And here we're comparing, again, on the right-hand side. Let's see how this works. So those who are using MCRP compared to those who are using paper tools. So you can see there wasn't much progress from baseline. Both groups were kind of pretty low. And end line both increased, which is great because they had that initial training, and we were also doing block meetings each month with all groups. But you can see that the increase was much higher for those who were using MCRP.
Did you control for the location of birth? So within that group, do you know who was delivering in the traditional way at home and who were going into facilities?
No.
Not necessarily on
Not,
this slide,
it's not something we controlled for. What we were measuring here was Asha's knowledge of these newborn danger signs, so their own knowledge, not the beneficiaries' knowledge.
Outcome. Okay.
And I'll get to that in a minute, but this was actually Asha's own knowledge, because she has to have the knowledge to be able to impart that during counseling. And then we also found that Ashas were much better able to assess newborns and recommend those who might need referral. The application uses these algorithms that I mentioned earlier so that they can use to assess newborns, and then they get coded as red, yellow, green in the application to know what needs to be done. And a red would mean that it needs to be referred, a yellow means that there might be some opportunity for home-based care, and a green means that there wasn't anything of concern. So for all of these measures, the Asha's using MCRP, which in this case is in blue, were able to do the assessments better. So the weighing, the measuring temperature, measuring stridor, difficulty in breathing, the breastfeeding, newborn skin. So they were doing those assessments better, but then they were also reaching a better diagnosis because the tool has the algorithm in it in terms of whether that newborn needed care or not. So now to your point about beneficiaries, which is also a very interesting question. If you remember, I said we surveyed 450 beneficiaries just to understand more about how Ashas were using the tool with them and how did they respond to it and did they understand it. And what we found is that those women who were visited by Ashas who used MCRP were much more likely to get counseling or about immediate breastfeeding, keeping the newborn warm, exclusive breastfeeding. So the quality and content of the counseling seemed to have improved from the beneficiary standpoint. But we also observed and measured that knowledge, as we all know, doesn't always translate into practice. So we weren't able to measure any, and again, it's not a huge sample and not a long time frame, but we weren't able to measure changes in some of those kind of outcomes that we would want in terms of newborn warmth and breastfeeding and what have you. Go ahead.
Did you attempt to measure it and it just wasn't significant, or did you just not measure it because of the small sample size?
No, we actually did try to measure it,
Okay.
but we didn't find any significant change in that. So we knew they were getting better counseling and they were getting better advice, but there hadn't been enough, that hadn't been sufficient to bring about some of these changes. So Asha's opinion, you saw a little in the video, but one of the things that's interesting is that they really seem to appreciate and value this tool on a number of dimensions. One, it's a lot easier than carrying around all those paper-based registers and flip books and other things. And a lot of times Asha's, sometimes they had that, sometimes they weren't supplied with that information either. So this is actually an easier thing to update. If you have new guidelines or what have you, you can just build them right into the application, where otherwise you're having to reproduce and print and distribute flip books and other things. So that's one of the advantages of these mobile operations. We also found that the beneficiaries really enjoyed listening to the videos, and so the Ashas were using them as a counseling tool. And to be honest, that wasn't one of our major objectives early on. It was really a self-learning tool. And so that was kind of an adaptation that the Ashas themselves did by showing the videos, the embedded videos, to complement what they were saying. And it seemed to carry a little bit more credibility sometimes, because here's this woman from their village that they've known all this time, and she's had some training, but then you bring that along with this embedded video image with these messages. It seemed to carry a little more weight. So I also want to talk a little bit about cost, because that's often a question that we have around sustainability. And we did a costing analysis as part of this to understand what the cost implications are. So in India, it costs about $73 for a smartphone, a little less expensive than your iPod 7s here. The training costs about $29 per Asha for the 5-day training that included both the little bit of refresher and then the use of the cell phone. Ongoing technical support, so we have people in the field who would be there to troubleshoot IT issues, or I can't turn my phone on, or my battery died, or what do I do? So you need to have that kind of backup and resource when you're giving these phones to women who haven't used them or have access to them before. And then the application development, server managed, the airtime, data usage works out to about $44 per Asha per year. And this is at a relatively small scale. We do think as it scales up, then there are economies to be introduced on some of these things. So basically, the startup costs are about $187, and then a recurring cost of about $85. So it's not insignificant. It's something, a cost that you would want to be able to drive lower. But then when you see how it really makes their work easier and potentially more effective, I think it holds some merit.
Well, I know you had mentioned that you weren't able to necessarily track birth outcomes. Would it be interesting if you started to do that, how that would correlate with cost savings as far as those birth complications or?
Yes, yeah, it would be very interesting to see that.
Even still, yeah, you're right. It's not insignificant, but compared to.
And to really track those outcomes at that level, you need so much larger sample than what we initially have. One thing I wanted to mention, I forgot to mention before about Ansaki, though, that's important, is that we designed this on an open source platform. So this is technology that's available to anybody and that can be adapted, and new modules can be added. And that's one of the things that's nice about it. It's not any kind of proprietary application. Where if you do need to change it, it's very expensive or costly, or you have licensing issues and what have you. So this is all on an open source platform, and that's very much the philosophy of a lot of these health innovations, and certainly the philosophy of our organization as we work in this space. So just to share some lessons learned and be interested again, for those of you who have worked in mHealth, some of your lessons. What we take away from this is that the applications, we have been able to demonstrate that they can improve both knowledge, skills, and practices of Ashas. We find that it really has some greater ability to provide real-time monitoring and supervision. So the A&M can check immediately whether the Ashas have been able to make the visits. The Asha can check immediately to know, oh, am I supposed to visit this woman today, or is it next week, according to the visit schedule that the government has. So it's much more real-time data than having to go through paper records or reports that you might not get till a month later when everybody gets together for their one meeting a month. The regular feedback and support that I mentioned, that technology support, we find is critical. This isn't something where you can just design an application and say, here, run with it. It does require support. It requires that capacity building, that a little bit of mentoring initially, and then that ongoing support. And one of the things that we think there's real potential for, but we have not been able to test completely yet, is the uptake of these applications. I think would be much greater, but because they're existing on a pilot level right now, the Ashas are still having to do a lot of the paper record keeping as well, because the government doesn't want to throw out the paper record keeping if you don't have a fully robust application. So it's a little hard in these testing stages in some respects in that way, because you're asking Ashas to use this tool to track the registry, but then they still have to fill in their paper-based forms. So the fact that they were using it as much as they were, even though it was something almost on top of what they had to do, is encouraging. Now, they didn't have to use flip books in the mobile application or anything, but just the reporting, they had to keep doing their paper reports. And that will probably be the case until the government goes completely to a mobile platform. Some of the limiting factors, gender inequities, I should say, in mobile phone ownership is a concern. Availability of services in rural areas. So you can have Ashas out there and recommending that women go to facilities for delivery, but if the quality of care at those facilities is poor, or the A&M isn't there, or the drugs aren't there, I mean, there's just so many issues that this isn't the solution for everything by any means. The whole system has to be strengthened. The cost, as I mentioned, I think could drive down with scale. Literacy, I hope you noticed that all of this was done in vernacular, so everything was in Hindi. And I think that's critical, because that's really the language these women are communicating in. So if it gets adapted to other contexts, it really needs to be adapted to the local language. Lack of electricity is a barrier that we have in some of these small villages where the electricity supply is not that reliable. Models for scalability and sustainability, I'll talk a little bit about. And then just the pace of technological advances. I mean, there are so many of these things happening out there, and you design something, and then a new guideline comes along, or a new technological advance comes along, and you're figuring out how to store the data. There are a lot of moving parts. And so when you think about scalability and sustainability, that becomes challenging as well, because at what point do you decide on a particular technology platform and then provide it to 800,000 Ashas, and then 2 weeks later you say, oh, here's a new one that's come out. Maybe that would have been better. So I think that sort of slows it down a little bit too, just because there's so much movement in this space. And so I wanted to, let me put all this up, but just to give you a better sense of the larger ecosystem that is there when you think about how do you scale these mHealth applications. So you can do the mobile phones, the training, the software application, but you really need to be looking at a broader scale on what is the mHealth policy in that country. Do they even have one? A lot of countries don't. So that's something that we're assisting in developing. What are the interoperability and integration that has to happen with different systems that the governments are using to track health outcomes, to track the facility level data, to track supplies, to track payroll. There's just so much of interoperability that's critical so these systems can communicate with each other. And then looking at how do you make a model that offers continuous value creation that can be adapted rapidly, and that those changes can be rolled out pretty easily. And then this is a changing way of doing things, and so change management in and of itself is something that we also need to be cognizant of and recognize as a challenge when you're trying to scale.
It just seems like, and here you have a very focused job role, but you have a lot of fairly siloed mHealth interventions. You know, like one thing in an area that might be for medication reminders, another thing that's for maternal child health, another thing that's for HIV care. And at a certain point, you're going to get mHealth fatigue if you're an individual living in that area. Okay, how many apps do I need to interact with? And you really need, if it's going to be a useful approach, there has to be some integration of all of this technology use.
That's exactly right, and I think where where things are going now is also to focus more on human-centered design and making sure that you're designing it with the person who's using it in mind. And we did that to quite a degree here because, in fact, IntraHealth organization I work for, we're not a technology organization at all. We're a public health organization and got our start out of the University of North Carolina Medical School. So we're all about health worker training and education. So we know the health worker side, and then we sort of developed this app. But a lot of times what you'll see are people developing apps and not having a deep understanding of who the user is. And that's why you end up with all these little bits and pieces. And it's also why the interoperability becomes really important. Go ahead.
So how did you consult for UX and UI design then? Because it sounds like you were involving UX and UI design when you designed the app. Did you talk to the health workers or did you?
Yeah, the design was done in country. So I know there were conversations with Ashas, and we'd been working with this cadre for a number of years. So we knew them and knew how they worked and what their responsibilities were. But we worked with local programmers in India to design the application.
Are these pilot findings published in an academic journal? Or just internally with your company?
They are published. I have a technical brief that's more grade literature. And I don't think they've been published in academic yet. We're in the process of doing that, and I'm trying to remember where we are in the process. So sorry for the hesitancy there.
I just say that because, a lot of great companies are doing great things, and it would be really beneficial to academia if this information was published and some of your findings was able to be applied,
That's right. And we have information on our website and others, but I completely agree with you and understand where you're coming from. And I want to talk a little bit about current status, though, because what I was sharing with you is our work that was originally funded by Bill and Melinda Gates Foundation in this block of Uttar Pradesh. But since then, we've really looked at trying to figure out, can we replicate this in other states? Can we modify it to meet other needs of the Ashas? So we've really turned our operation in UP into what we call an mHealth lab. And that's been a collaborative effort throughout with the National Health Mission, with the government of UP, and with IntraHealth. And we now have support from Qualcomm Wireless Reach. So Qualcomm's a big, what do they make? Processors. And have a program to try to promote mHealth. So they're supporting some of our work now. And we've introduced MSaki to the Anganwadi worker who's doing some of the nutrition and early childhood education and modified the modules to design it for their application. We're also replicating it in Uttarakhand. Uttarakhand's an interesting state. It's right in the Himalayas. So it's got a very mountainous terrain. It's very difficult to access services sometimes. So again, we thought an ideal place for Ashas to have better job aids and better almost virtual supervision, because otherwise it's really hard to have any kind of supervision, particularly in the winter when some of the roads close. So we're working on that now with some funding from another private foundation and working at a larger scale. So we're working with 230 frontline health workers there. And then we're also adapting MSaki for Ashas again, but to address non-communicable diseases. And this is through some funding we have from Medtronics. In India, as you may know, India has an enormous non-communicable disease problems as well, particularly hypertension and diabetes. So Ashas are increasingly being asked to maybe be that first-line screen or counselor to identify potential cases of diabetes. So we're going to be developing a module to help them do that. And again, a little bit proof of concept, but it'll be a new area for Ashas to be in. And then based on this early work, the government of Uttar Pradesh has decided to really try to work with mobile health applications and is developing an application that has some of the features of MSaki and some other features to do this at a large scale. So this would be 12,000 frontline health workers. Still far short. That's 10% of the total number of Ashas in the state. But 10% is still a scale that a lot of mHealth applications haven't gotten to. So they're rolling that out in 5 districts in the state that will reach about 100 million population. So we're going to see over time some of these things get to scale. Certainly not all of them, and not all of them should. But there are challenges in how do you bring it to scale? There's just so many more complexities that then get brought into that when you have these environments that really don't have a lot of systems or structures to support that kind of technological innovation very easily.
I know in some developing countries, a network often goes out during monsoon season. Do you guys experience any difficulty with storage of the data if there's no network service at the moment, or if there's power's gone out due to monsoon? How do you charge the phones and transmit the data?
Yeah, good question. So MCRP, the counseling and the video and all is actually on the phone. So that's what's nice about that is it doesn't require some kind of wireless connectivity to be able to use. And then data can be entered and it gets transmitted electronically once somebody is in a space where they have access to wireless. So you can enter the data and it can be stored. That doesn't address the issue of charging and what happens when you have limited access to power. Do you have problems with phone charging? To date, we haven't had that problem in the places that we are working, but that may be a problem, particularly as we continue to do this work in Uttar and some of these harder to reach areas. And there I know what some other organizations have done in some countries, particularly in Africa, is tried to do more with solar batteries and things.
Could you ever see a client version of this application where they access the education themselves, maybe communicate with the Asha if they needed assistance, things along those lines?
I think that could be there, and it's an interesting, and those kinds of applications, some of them I'm sure exist in the private sector for educated Indian women, just as they do here. Yeah. I think it may be a little bit time yet before it's reaching the beneficiaries at these village levels, because they're, I'm going to get my number wrong, but not orders of magnitude wrong. I think it's like 40 or 50% of women are illiterate at the village level in India.
It's just interesting how engaged they were looking at it. You know, so the Asha has a visit, they see the video, they might later that day say, "Oh, I wish I could look at that again."
That's right.
You created the relationship with that initial encounter, and there's potential opportunities to build on it if you develop.
And I think as smartphones reach further to the village and to that beneficiary level, they will. They're not there yet. A lot of people might have they'll have a mobile phone, but not a smartphone. It'll be like one mobile phone for the whole family. So hopefully, I mean, that's certainly a vision of where we would want to get to. How fast we're going to get there is the only thing. We have these wonderful stories when we talk to these Ashas who are using MCRP, just how having that mobile phone and the smartphone has really empowered them. Because they're just like their beneficiaries, right? There's really no difference. They're recruited from the village. But there are these wonderful stories of empowerment that they tell. Because they have this respect and credibility in the community, and they've learned these new skills now of how to use a phone and access information. So that's been really exciting for us to see, because that's empowerment at the community health worker level. The next step would certainly be the beneficiary, but we're seeing it at the community health worker, who is really just not even a step away from the beneficiary. It's just that maybe they already had their child. Go ahead.
Have there been any talks or thoughts about using this platform in other low-resource settings outside of India, like in other countries? I know you'd have to change the content a bit, like to tailor it to the setting, but have you talked about using this platform?
Yes, we have talked about it. One of the challenges that we face is we're an international nonprofit organization, and so we need people to fund our work. Mm-hmm. And so we work in 35 countries, but unless we have a donor who wants us to do that, or that we can propose to do that, we actually have sort of a hard time rolling that out, which is the challenge of working in this space. So I think it does have a lot of potential, and there are other applications like this in some other countries that others have developed. I know Tanzania has what do they call it? Oh, I'm forgetting the name right now. Mother care, something like that. There's a model in Tanzania that's being used. In Africa, most of the times the models are not so much on smartphone applications, though, and that's where India is a little bit further along. But that's going to change soon too. Any other questions? Well, I really appreciate the questions that you did ask and your comments. It's been really helpful, and I look forward to getting the answers to those that I couldn't answer. But thank you all very much for your attention.
Something about mobile money in that.
Sure.
So if they lose the phone, do they lose their money?
No, I think